Good morning to all. Today's seminar topic is about the histopathology of psoriasiforms and lichenoid interface dermatitis. Myself, Dr. Pooja. Psoriasiform pattern is usually defined histologically by finding the elongated dermatitis, which is roughly equal length and alternate with a long dermal papilla. This psoriasiform tissue reaction can occur in the various inflammatory dermatoses, which includes psoriasis and its variants, Pityriasis rubra pilaris, parapsoriasis, subacute and chronic spongiotic dermatitis, lichen simplex chronicus, prurigo nodularis, chronic candidosis and dermatophytosis, inflammatory linear verrucous epidermal nevus, nutritional dermatosis like the pellagra, and a clear cell acanthoma. It can also find in the dermatofibroma and the Woven's disease. While looking into the histopathological image of the psoriasiform dermatosis, it's very important to have a look on the scanning magnification, that is the 2x and the 4x power of the microscope, to look for the presence, if there is a presence of evenly elongated thin retices with the equal long dermal papilla, it implies only one condition, that is psoriasis, because other psoriasiforms pattern will have the uneven psoriasis pattern, that is the retices are of uneven length and the thickness with a thick suprapapillary plate. One should look into the depth and the pattern of the inflammatory dermal infiltrates, whether it is superficial or the deep or the both superficial and deep dermal infiltrate, and the pattern, that is whether it is a perivascular, lichenoid or the nodular. In psoriasiform dermatosis, the normal vascular weave pattern of the stratum corneum is lost, and it is very common to find parakeratosis. So basically, parakeratosis is the presence of nuclei within a cornified layer. It occurs due to the rapid turnover of the epidermal keratinocyte. In the histological image, if there is a presence of the normal vascular weave pattern above the parakeratotic layers, it indicates the recent onset of the disease. This parakeratosis can be in the form of small mounds, it can be broad or it can be confluent. Parakeratosis can be present throughout the epidermis, like in the psoriasis, or it is located around the infundibulum ostia, like the seborrheic dermatitis, or it can be present in the both form, like in the pityriasis rubra pilaris. Confluent parakeratosis can be seen in the dermatophytosis, syphilis, Pityriasis lichenoid chronica and the mycosis fungoides. If there is a chronic and atypical parakeratotic nuclei, this gives a clue for the Woven's disease. Since the psoriasis is the prototype of the psoriasiform dermatosis, however, the histological findings depend upon the different phases of the psoriasis. In the early phase of the psoriasis, histological findings includes mounts of the parakeratosis with the neutrophils. As shown in the image with the numbers, there will be the thin granular layer, moderate acanthosis with the focal spongiosis, and there is increased mitotic figures, particularly suprabasal, and there is a dilated blood vessel at the tip of the dermal papilla, with the perivascular infiltrate of the lymphocyte and very few neutrophils. In the well-developed psoriasis plaque, the histological finding includes the confluent parakeratosis with the collection of the neutrophils. There will be the absent granular layer, acanthosis with the club-shaped retices. These retices will be markedly elongated and it is of the even length, and there will be the thin suprapapillary epidermal plate with the suprabasal mitosis, and there is overall pallor of the upper dermis because of neutrophils migration, and there is a dilated tortuous vessels in the dermal papilla with the perivascular infiltrates. Histological findings of this image shows the first image shows the spongiform pustules of the Kozak, which is formed by the collection of the neutrophils in the spinous and the granular layer. The second image, it also shows the neutrophilic collection between the parakeratotic cornified layer, which is known as the Monro microabscess, which is characteristics of the psoriasis. In the eruptive psoriasis, there will be the multi-layered mounds of the parakeratosis, which is admixed with the basket weave orthokeratosis, where the slight acanthosis, and the dilated blood vessels in the dermal papillae along with the dermal infiltrate around the perivascular and the upper dermis. There is a term used for the papilla in the psoriasis which is known as the skirting papilla, which is basically histological finding in which the neutrophils are absorbed migrating from the dermal papilla into the epidermis. As histological findings varies in the various stages of the psoriasis and other forms of psoriasis, the most reliable sign of the psoriasis will be the dilated and the tortured papillae, which is present in almost every stage and the form. Second entity, pityriasis rosea. The histological findings of the pityriasis rosea include mounts of the parakeratosis, where there will be the decreased granular layer, which is also known as the Lobeck-Watt sign, in the name of the scientist Lobeck-Watt. There will be the moderate acanthosis, moderate spongiosis, and there is a superficial perivascular infiltrate of the lymphocyte and the extravasated erythrocyte that extends into the epidermis. This extravasation of erythrocytes indicates the sign of the acute process which can be seen in the pityriasis rosea and also seen in the acute form of the pityriasis lichenoides. And this extravasated erythrocytes in the epidermis is also known as Savarot sign. There is other signs related to pityriasis rosea finding, which is known as the salute sign or the T-spot sign, which is basically the parakeratosis which is attached on one side and free on the other side. There is a Una sign, which is the eczematoid pattern of the pityriasis rosea. Next entity is the pityriasis rubra pilaris. The histological finding of pityriasis rubra pilaris include hyperkeratosis with the follicular plaque, which is shown in the number 1, which is the keratin plaque follicles. The parakeratosis is adjacent to the both sides of the follicular ostium, which is termed as the shoulder parakeratosis. And there will be the alternate ortho and the parakeratosis pattern, which is given the name checkered board pattern of the parakeratosis. There will be the irregular psoriasiform acanthosis, as shown in the checkerboard pattern is shown in the second image in the number 3, and there will be the irregular psoriasiform acanthosis. The interfollicular epidermis often exhibit the hypergranulosis as well as the thick and shortened retipes. There will be a scarce superficial dermal perivascular lymphohistiocyte infiltrate, and there will lack of the neutrophil which differentiate it from the psoriasis. The next entity is the digitate dermatosis, small plaque parasitosis. As shown in the histological image, there is a characteristic elongated mound of the parakeratosis with the collection of the plasma cells above a basket with conified layer. There will be the preserved granular layer, and then there will be minimal acanthosis and with the sparse superficial perivascular lymphocytic infiltrate. Next entity is auxiliary granular parakeratosis. This is characterized by the marked compact parakeratosis with the small bluish granules within the stratum corneum, which represents the keratohyaline granules, which is the characteristics of the stratum granulosum layer. This next slide includes the comparison between different disease of the psoriasis forms. For psoriasis, contact dermatitis, seborrheic dermatitis, pityriasis rubra pilaris. So the features parakeratosis. In the psoriasis, there will be the confluent parakeratosis present. In the contact dermatitis, there will be the focal, and the seborrheic keratosis, it deals with the mounds of the parakeratosis, which is basically around the infundibular lips. In the pityriasis rubra pilaris, there is a characteristic term checkerboard parakeratosis. Second feature, acanthosis, which is even in the psoriasis, however, it is uneven in the all other entities. Granular layer is absent in the psoriasis and is present in all other entities like the contact dermatitis, seborrheic dermatitis, pityriasis rubra pilaris, and it is very prominent in the pityriasis rubra pilaris, particularly the interfollicular epidermis. Features suprapapillary plate, which is the thin in the psoriasis and the thickened in the pityriasis rubra pilaris, and it normally the contact dermatitis and seborrheic dermatitis. Pallor of the upper epidermis, it is present in the psoriasis, however it is absent in all other features. Spongiosis, there will be scant with no vesicle formation in the psoriasis. Contact dermatitis will be having the prominent spongiosis with the vesicles formation. In the seborrheic dermatitis, there will be the mild surface and present in the surface and infundibular area. However, it is absent in the pityriasis rubra pilaris. Neutrophils in the epidermis is present in the psoriasis, however absent in the other entities. Mitosis is very common in the psoriasis, particularly in the suprabasal layer. However, it is absent in the other entities. Dermal papillaris is markedly tortuous in the psoriasis. In the contact dermatitis, it is dilated, but it's not tortuous. In the seborrheic dermatitis, it is mildly dilated, and in the pityriasis rubra pilaris, it is dilated but not tortuous. About the dermal infiltrate, in the psoriasis, there will be the lymphocyte with the no eosinophils. However, in the contact dermatitis, there will be the lymphocyte and will be having the many eosinophils. And the seborrheic dermatitis and pityriasis rubra pilaris also have the dermal infiltrate as a lymphocyte. Next entity is a lichen simplex chronicus. Lichen simplex chronicus histological findings include hyperkeratosis, irregular acanthosis, hypergranulosis, and the dermal fibrosis, and the chronic inflammatory perivascular infiltrate, which can be seen in the histological image. The characteristics finding here is the vertically oriented papillary collagen bundles, which is in the upper dermis. This finding can also seen in the prurigo nodularis as well as lichen simplex chronicus. Next entity is inflammatory linear verrucous epidermal nevus. The characteristics finding of this entity includes alternating elevated foci of the parakeratosis with the absent granular layer, with a depressed foci of orthokeratosis with a preserved granular layer. There is the moderate acanthosis with elongated retidices. Basically, inflammatory linear verrucous epidermal nevus is sharply defined, having the thick zone of the parakeratosis, which is alternating with the orthokeratosis, and there will be the mild papillomatosis. Next slide is this shows actually the sandwich sign, which is a fungal element which is sandwiched between upper zone of the orthokeratosis and the lower zone of the parakeratosis or the compact orthokeratosis. Next histological finding shows a very thick compact orthokeratosis which mimics the palm surface, but the presence of the follicular sebaceous unit gives the clue about the diagnosis, that is the prurigo nodularis or the lichen simplex canicus. Basically, this sign is known as a hairy